All right, guys, welcome back to Underground Science. In this video, we'll be talking about Truncus arteriosus. Okay, so just a brief overview. This is an embryological defect, right? So if we remember from embryology, just a quick snapshot, we have the aortic pulmonary septum, right? And that's supposed to eventually split into two separate tracts. One is going to be the aorta, and the other is going to be the pulmonary artery, right? But in this disease, in truncus arteriosus, the trunk does not split into the pulmonary artery and aorta. Okay, it's one big tube, and we'll see what that is right now, actually. So I know this isn't the best drawing, but just to get the point across, right? So if we look at this, so this is our right side of the heart, left side of the heart, right? This is our right atrium, left atrium. There's supposed to be an intraventricular septum here, but in truncus arteriosus, you have a VSD, okay, a ventricular septal defect. So there's an opening, there's a huge opening between the right and left ventricle. So that means that the blood that's coming on the right side and the blood that's coming to the left side will mix, right? So remember the right side, whatever blood comes to the right side of the heart is deoxygenated, right? Whatever blood that's coming to the left side of the heart is oxygenated. Why? Because whatever blood is coming to the left side of the heart, remember, it's just coming from the lungs, and the lungs are full of oxygen. So the blood that's coming from the lungs to the left side of the heart is oxygenated, okay? And the blood that's coming into the right side of the heart is not oxygenated, it's deoxygenated, okay? It has low partial pressure of oxygen. But in this case, what's going to happen is as the deoxygenated blood, right, comes into the right side of the heart, it's going to mix with the oxygenated blood in the left side of the heart. So if these two mix, right, then you're not, the partial pressure of oxygen is going to go down inside that blood now. And what happens is because there's one single tube, right, the trunk did not split into the aorta and pulmonary artery. There's one single tube. So the mixed blood actually goes into that single tube, right? Then you get the aorta and pulmonary artery. So it does not split right away. You get that later on. Okay, so this single tube right here is what truncus arteriosus is, right? So this is the truncal valve, right? This is the truncal semilunar valve. You get you get oxygenated blood in the left ventricle, deoxygenated blood in the right ventricle, right? Usually what's supposed to happen? Usually you get this, right? So let's erase that and let's go down to a normal heart, which I try to draw a rough sketch here. So usually what happens is that let's draw this. Let's draw these branches of the aorta. Okay. So usually we see, right? We see this. So deoxygenated blood is coming down here through the superior vena cava and enters the right atrium, right? And so let's draw our valves for this so we can just have a separation of the right atrium and right ventricle. So this is going to be our tricuspid valve, right? So we get deoxygenated blood here that arrives. And then from here, it goes through the tricuspid valve into the right ventricle. Okay, so it's still deoxygenated. Then from the right ventricle, remember, we have, let's draw the valves here. Let's draw the pulmonic valve. It's one of our semilunar valves. From the right ventricle, our deoxygenated blood, remember, goes through the pulmonic valve, right, into the pulmonary artery and goes to both of our lungs, right? And then from our lungs, it gets deoxygenated. So now we have high oxygen blood, and that comes back through our pulmonary veins. Okay, that comes back through our pulmonary veins into the left side of the heart. So this now we're in the left atrium. This is our other valve. This is our bicuspid valve, right? Or our mitral valve. And once our high oxygenated blood is here. It's going to come down through the mitral valve and into the left ventricle, and then this oxygenated blood will be pumped, right, through the aortic valve into the aorta and then out to our systemic circulation, right? So that's the normal pathway. But in truncus arteriosus, remember, there is no, there's not one side or the other. It's mixed, right? There is no right ventricle to pulmonary artery and left ventricle to aorta. So what happens here again, remember you have oxygenated blood and deoxygenated blood that mix together because of the VSD, and then this blood gets pumped into a common tube. Okay, that's what truncus arteriosus is with a truncal valve. Okay, so it gets pumped into a common tube, and then that blood gets pumped into the aorta and the pulmonary artery. So you can think, why that's bad is because if you have deoxygenated blood and oxygenated blood mixing every time the heart contracts, then you're having a lower partial pressure of oxygen going into your systemic circulation and lower partial pressure of oxygen going to your lungs, right? So let's talk about the findings more. So that's just the basic overview of what truncus arteriosus is. Now let's dive more deep into the findings and explain each one. So as we said, right? So let's say the baby's born. Okay, we know that in the beginning, right? In the beginning, what's the resistance like in the lungs of the baby? So the pulmonary vascular resistance is high, right? Right when they're born. So we can write that down. So the pulmonary vascular resistance is high when they're born. But as time progresses, right, as days go on, after a couple weeks, pulmonary vascular resistance will fall. Okay, it's going to fall after birth. Let's say after a few days, maybe up to a week or two. So if pulmonary vascular resistance later on falls, then that means the lungs, right, the blood vessels in the lungs are lower pressure, is a low pressure system. And fluid likes to go from high to low pressure. So as the weeks progress, pulmonary vascular resistance will fall, and more blood now will go into the pulmonary vasculature, right? So you're going to have a lot of blood going to the pulmonary vasculature. Why is that bad? Well, that can lead to pulmonary edema, right? If you get pulmonary edema, obviously the baby's going to have a really hard time breathing. Okay, so the work of breathing will go up, right? You'll have fast breathing, labored breathing, and so on, which we'll talk about soon. But that's what happened. That's a really important thing to remember. And because there's a lot of blood rushing to the lungs now, right? Because the pulmonary vascular resistance is low, what happens after when blood goes to the lungs? It comes back around to the left side of the heart, right? So if there's a lot of blood now going towards the lungs, that means that there's going to be a lot of blood then coming back to the left side of the heart, right? There's going to be a lot of blood coming to the left side of the heart. If there's a lot of blood coming back to the left side of the heart, it would make sense that the left side now will get strained, right? It's going to get overstrained. It's going to get overworked because of that massive pulmonary venous return. If the left side of the heart gets overworked, that can lead to volume overload and congestive heart failure, right? Which is why one of the other findings of truncus arteriosus is congestive heart failure. Okay, so let's keep on going. Let's dive deep into the symptoms and findings. Okay, now that we know a basic overview. So the first finding that we should discuss is definitely going to be cyanosis, right? Why is there cyanosis? Because we have mixing of blood. We have mixing of blood between the left ventricle and the right ventricle because of the VSD. So remember, if we have the right ventricle here, and we're not going to draw like the entire thing, right? But if we have the right ventricle here, you have that VSD, and then you have the left ventricle here, right? Now we're supposed to have the septum here, but there is no septum. There's a VSD, right, in truncus arteriosus. So we don't, let's go and erase that. So we have a large ventricular septal defect. Okay, so let's just continue this. And let's say our ventricular septal defect is right here. And from the VSD, you get one common trunk, remember, right? So if you have if you have oxygenated blood here, deoxygenated blood here, and they mix, right? And then you go into the common trunk, and after that, you get pumped out, right, into the aorta and into the pulmonary artery. Then, of course, you're going to have a lower partial pressure of oxygen that's going into the systemic circulation, right? Because usually fully oxygenated blood gets pumped separately into the aorta, deoxygenated blood gets pumped separately into the pulmonary artery. In this case, they're both mixing, and then you're going into the systemic circulation. So that's why you see cyanosis, right? You see decreased partial pressure of oxygen, and you'll see that cyanosis, like let's say in the baby's lips or nail beds, right? For example. So I hope cyanosis makes sense because you're mixing low oxygenated blood and high oxygenated blood together. If you mix that together, then you're going to have a lower partial pressure of oxygen inside your systemic circulation, right? So cyanosis is one finding. Then another finding that we've already touched on is going to be respiratory distress, right? So respiratory distress. Why is there respiratory distress? Well, because we said as pulmonary vascular resistance drops after birth, right, fluid likes to go from high pressure to low pressure. So if pulmonary vascular resistance drops, more blood will be shunted towards the lungs, right? So when the heart pumps, more blood will be shunted towards the lungs. If more blood is going towards the lungs, right? So if we have a lot of blood now going towards the lungs, why? Pulmonary vascular resistance is low, okay, after birth. Then that means that all that blood will have to, where is it going to eventually end up, right? Because remember, what's the flow of blood throughout the heart? It goes from the heart to the lungs and back to the heart, right? Back to the left side. So all that extra blood that's being shunted to the lungs will eventually come back to the left atrium and then to the left ventricle. So that means that that means that the left ventricle will get overstrained. But in terms of respiratory distress, if you're getting a lot of blood to the lungs, that can lead to pulmonary edema, right? Which can lead to respiratory distress, especially because of the fact that if you have fluid in your lungs, right? So if we draw one alveoli like this, and you have a bunch of fluid, right here, then of course it's going to make it very hard not only to breathe, but for oxygen to go from your alveoli to the blood vessels beneath it, right? So that's why you'll see respiratory distress, trouble breathing. You'll see fast breathing, labored breathing because of the excess fluid going to the lungs. So that's the pulmonary overcirculation finding that we had to discuss. So what did we say will come out of this? You'll see fast breathing, see overcirculation, right? Overcirculation, especially pulmonary overcirculation. Fast breathing, why? Because of course you're gonna have a lot of fluid buildup here. It's gonna take more effort for the baby to expand their lungs and for specifically for oxygen to go into the um, pulmonary vasculature. And so that explains the respiratory distress finding, right? The other finding that we have to discuss is going to be poor feeding. Okay, so why would there be poor feeding? Okay, let's write this down. So there's going to be poor feeding and sweating while feeding, right? So diaphoresis, fatigue, we can write that down too. But let's explain why this happens. Now, in Truncus arteriosus, we see poor feeding because of congestive heart failure. Remember, if there's a lot of blood being shunted to the lungs, that blood will eventually come down to the left side of the heart, right? To the left atrium and the left ventricle. So now the left atrium and left ventricle is getting volume overloaded, right? that means there's going to be too much strain on the left side of the heart, leading to congestive heart failure. The left side won't be able to pump that much fluid. Okay, so we're going to get heart, not only congestive heart failure, but that blood will begin to back up. Okay, so that's the reason you see fatigue and poor feeding, because there's a lot of muscles involved in feeding, right? So if you increase the metabolic demand while the baby's trying to feed, the heart's already having trouble, right? Because it's in congestive heart failure, it can't pump that much fluid out into the systemic circulation. On top of that, you're raising metabolic demand by feeding, right? Because there's a lot of muscles involved in that process. So your muscles need ATP, right? And how do you get ATP? From oxygen. But if your heart is failing and you can't pump that oxygenated blood in your systemic circulation, then of course you're going to show signs of fatigue and you're going to get really tired, right? Trying to feed and you're going to sweat. So that's why you see poor feeding, diaphoresis with feeds, and fatigue. Now, the next finding similar to this is failure to thrive. Okay, why do you see failure to thrive in this disease? Well, because normally, right, you as you're growing and developing, you need calories to do that, right? You need calories to grow and develop properly. But because your lungs are filling with fluid, the baby's having an extremely hard time trying to get that air in, trying to expand those lungs, trying to breathe, right? The work of breathing is really high, as we discussed. On top of that, you're not able to pump properly, right? Because your heart's failing. So a lot of that calories, a lot of that work is being used to properly breathe, to properly get that air in. So the work of breathing is using up a lot of the calories of the baby. And so you're not getting calories diverted to growing, you're getting calories used to breathe, right? So that's why failure to thrive can happen. Um, so what did we say? We said you're using a lot of calories to breathe, right? Because the work of breathing is so high. So you're diverting your calories for things like breathing, and you're not able to use those calories to grow, to properly grow and develop. See, that's why you see failure to thrive. And as blood backs up, right? Remember, as blood backs up, it can back up into your organs, right? So you can see hepatomegaly, for example, right? You can see hepatomegaly, for example, because remember, as blood backs up, as your left side of the heart's failing, it can back up to your right side of the heart, right? Eventually go to your right side of the heart. And remember, so this, if your left, let's just say left side of the heart, if that's failing, it can't pump blood forward, right? So where's the blood eventually going to go? It's going to eventually back up to your pulmonary vasculature, and from there, it's going to go to your right side of the heart. And what feeds into the right side of your heart? Your superior vena cava, inferior vena cava, right? Those are large veins. If we take your liver has veins draining it that eventually dumps into the inferior vena cava, right? That's a horrible liver. But so if blood is backing up now to the right side of the heart and eventually into your blood vessels that put blood into the right side of the heart, like your superior and inferior vena cava, then it makes sense that as the pressure builds up, we're going to have hepatomegaly, right? Because then blood will back up into the veins draining the liver, which can lead to enlargement of the liver, right? That can lead to venous congestion. So that's why you see hepatomegaly. Okay, that's why one of the findings can be hepatomegaly and truncus arteriosus. Okay, so we talked about cyanosis, right? We talked about tachypnea, right? Fast breathing, labored breathing because of the pulmonary edema. Another cool thing to know for this disease, remember heart sounds, right? When we're talking about heart sounds, we have lub dub, okay? So we have the S1 heart sound and the S2 heart sound, right? Mainly. We know the S1 heart sound is what? What makes up the S1 heart sound? This is the closure of your tricuspid valve and mitral valve, right? And then we know S2, what makes up S2? The S2 heart sound. That's the closure of your semilunar valves, right? So your aortic and pulmonic valve. Now remember, in truncus arteriosus, we don't have an aortic valve or we don't have a pulmonic valve. We have one single semilunar truncal valve. Okay, so there is no aortic valve and there is no pulmonic valve. There's one single semilunar truncal valve. Okay, so you're going to hear a loud S2. Why a loud S2? Because you're pumping so much blood across that single truncal valve that when it closes, it's going to be very loud because of the pressure in front of it, right? So if we draw that single tube, right, single truncal tube, this is our truncal valve. Remember, we have our right ventricle here, left ventricle here, and we have that VSD, so the blood mixes. You're pumping the blood in the left ventricle and the blood in the right ventricle, all of that across one single valve. So if you pump this blood forward, all of that blood will then have that back pressure against the valve, causing it to slam shut really hard. Okay, so that's why you have a loud S2. So that's one finding that we should list and write down here. Loud S2 is you'll hear a single loud S2 because of why? Because you only have one semilunar truncal valve. That is you're pumping the blood in the left ventricle and the blood in the right ventricle across that valve. Okay, so that's a lot of blood right here. That means there's a lot of back pressure telling the truncal valve to slam shut really hard. Okay, and talking about heart sounds, we can also talk about heart murmurs. Because you only have one truncal valve dealing with all of this blood that's flowing across of it, you can have murmurs, right? So you can have if that truncal valve is stenosed, right? It's possible in truncus arteriosus for the truncal valve to be stenosed. If it's stenosed, right, what murmur do we usually hear with stenosis, right? We hear a systolic ejection murmur. We hear a systolic ejection murmur, right? So remember, if a valve is stenosed, then like for example, if we see aortic stenosis, right? So when the heart pumps against the aortic valve, right, you're going to hear that murmur. That it's going to be a crescendo murmur, right? So if we look at um, if we depict that right with a drawing, so you have your S1 here, okay? So when the heart contracts, your mitral valve and your tricuspid valve will close. That's your S1, right? But as the blood flows across that stenosed aortic valve, right? We're talking about aortic stenosis here. You're going to have that crescendo murmur, right? So you're going to have a crescendo murmur like this, and then you're going to have that S2, right? Which is going to be your aortic valve and pulmonic valve closing, right? So this is depicting aortic stenosis, okay? We're just talking about this as an example because you're going to have a similar finding in truncus arteriosus if you have a stenosed truncal valve. So we see in aortic stenosis, right, you're going to have that crescendo, decrescendo murmur. Okay, so you're going to have a crescendo, decrescendo murmur. Why? Because you're pumping a lot of blood across the aortic valve that's stenosed. That's why you had that crescendo, and then followed by a decreased amount of blood, right? The rest of the blood going into the aorta, so that's the decrescendo. So you're going to have a similar systolic ejection murmur in truncal valve stenosis. Okay, so that's one thing to know. But you can also have the opposite. This truncal valve could be leaky, so you can have truncal valve regurgitation. So similar to aortic regurgitation, right? What do we hear in aortic regurgitation? We have that S1, right? And then we can draw our S2 line here, right? So we're gonna have our heart contracts, okay? We're gonna have the mitral valve and the tricuspid valve close. Blood will rush through our aortic valve and pulmonic valve, right? And go into the aortic circulation and pulmonary circulation. But once it comes time for the aortic valve to close, it doesn't close properly, right? That's why we have regurgitation. So you see the classic diastolic decrescendo murmur, right? With aortic regurgitation. Similarly, you're pumping a lot of blood across the truncal valve. If that's leaky, you're going to get that similar diastolic decrescendo murmur there too if you have truncal regurgitation, right? So this is depicting aortic regurgitation, but similarly, you'll also see a diastolic decrescendo murmur if the truncal valve is leaky. Okay, that's why you could see truncal regurgitation. Now, remember, the main thing is we have a VSD, right? Remember, we have that VSD between if we draw the right side like this and the left side, we don't have that intraventricular septum. We have a large VSD there, which causes the blood to mix. VSDs cause a polysystolic murmur, right? Because of that turbulent blood flow across that septal defect. So you can also expect to see a holosystolic murmur. Okay, what does that look like if we depict that as a drawing? So if we draw our S1 here and our S2 here, a holosystolic murmur is between the S1 and S2. You're going to get a constant murmur. Okay, because as the ventricles are contracting, right, there's blood flow across this VSD. So that's why you're going to get that murmur across the whole time period between S1 and S2. Okay, and so those are the three main murmurs that we should be familiar with. And then that's basically the main physiology, the pathophysiology of truncus arteriosus. If we talk about certain tests, just real quick, before we end this, there's a test called the hyperoxia test. Okay, and what that test is if you give 100% oxygen to these patients, right, to these babies, the arterial oxygen will not rise much at all. Okay, it's going to rise a little bit, but it won't return to normal. So if you're giving 100% oxygen, right, normally if you give 100% oxygen to someone that has low oxygen, you're expecting the oxygen to rise, right? Like in order to rise to a normal level. But in these babies, remember, if you give 100% oxygen, it'll rise very little. It won't rise much. Okay, so it won't get to normal stages or normal oxygen levels. And the reason for that is, remember, because you're mixing that blood because of the VSD. So no matter how much oxygen you give, when that blood comes to the heart, they're gonna mix. The oxygenated blood and the deoxygenated blood will mix. So no matter how much oxygen you give, it won't ever become normal. Okay. So that's one main thing. And of course, if you did an X-ray, you could see that congestive heart failure, the blood filling inside of the heart. So you can see cardiomegaly if you were to do that chest X-ray, because remember of that left ventricular volume overload. And if you wanted to see that single trunk, that single great vessel overriding the VSD, you can see that in an echocardiogram, right? If you did an echocardiogram, then you would see that single great vessel overriding the VSD, okay? So if you had that VSD here, you would see that trunk coming off of it, okay? So those are some tests and imaging that we covered, which is good. One last thing that we should talk about is the fact that this can be associated with another disease that we talked about in a previous video called DiGeorge syndrome. Okay, so remember, we did talk about DiGeorge syndrome in another video where we said not only can you find heart defects, but you also have, right, you also have hypoplasia of your thymus. So your thymus is smaller than usual, right? Hypoplasia of thymus. And remember, you don't secrete as much PTH. Okay, so that's going to lead to hypocalcemia. Okay, so you not only do you have heart defects, but you also have hypocalcemia and thymic hypoplasia, right? What heart defects do we see? Well, truncus arteriosus, right, which we talked about right now. Plus, you can see things like tetralogy of Fallot, for example. Okay, and so that's basically it, right? If and look, how would you treat this? You would treat this via surgery, right? So you try to make two separate tracts. You would try to connect the left ventricle with the truncal root, making a neo-aorta, right? So you try to make one tract going from the left ventricle to the aorta and another tract going from the right ventricle to pulmonary arteries. That way you have two separate tracts, so you don't have mixing of oxygenated blood and deoxygenated blood. Okay, and that's basically it, right? That's truncus arteriosus. Hopefully it made a little bit of sense. Hopefully it helped a little bit. Thank you guys for watching and see you guys in my future videos.